Hello, professional nurses. Mrs. Ignacio, this is our nursing huddle on cardiovascular system disorders. All right, so let's go ahead and jump in and start off with the assessment. So your general survey always remains the same, introducing yourself, hand hygiene. You're going to assess the level of consciousness, right? The mood, the affect, assessing for pain, the use of any mobility aids, or you're also going to take the vital signs, and you will also then look at the skin, the moisture, the temperature, right? Is the color appropriate for ethnicity? You're also going to assess for capillary refill and for clubbing. That's going to be important. Remember, capillary refill, the color should return in less than 3 seconds. You're also going to look at the color of the palpebral conjunctiva in both eyes. That's the lower eyelids. Remember, don't use hand sanitizer and then pull your patient's eyes down because that will burn their eyes. You want to have your hands with gloves on. That's going to be important. I have seen some test questions with someone using hand sanitizer and then pulling down their patient's eyelids. That's going to be important because that alcohol will burn the eyes. The palpebral conjunctiva should be pink and moist. The next thing that we're going to do in our cardiovascular assessment is going to palpate the carotid arteries. That's going to be one at a time. That's going to be important because you don't want to cut off circulation to the brain, right? So palpate the carotid arteries one at a time. We are inspecting and assessing for amplitude, rate, and rhythm. Okay, so is it strong or weak? Is it regular, irregular? Do they have an absent, right, pulse? That will be 0. If it's diminished or barely palpable, that will be a 1. If it is normal, it's going to be a 2. And if it's full and strong, it will be 3. And if it's bounding, as in the case of fluid volume overload, that will be a 4. We will also auscultate, listening with the bell of our stethoscope to each of the carotid arteries. We're listening for bruits. Remember, a bruit is a loud, whooshing, turbulent sound, and this is an abnormal finding. We will also inspect a patient, making sure that they're sitting at a 45-degree angle. We are looking for jugulovenous distension. If they have that bulging neck vein, right, that is a positive sign of jugulovenous distension, and that is a sign of fluid volume overload as well, okay? We also want to remember the cardiac landmarks, and we can use ape to man or all people, read Time magazine, but these cardiac landmarks go with the cardiac valves. We have 4 cardiac valves, and so we're going to auscultate first using the diaphragm of the stethoscope and then the bell of the stethoscope. Okay, so we'll listen to the aortic valve first, and that is on the right second intercostal space, right on the sternal border. And then you will move to the left for the pulmonic valve, and that is the second left intercostal space. Then you will auscultate for the tricuspid valve on the fourth intercostal space on the left sternal border, and then your mitral valve, which is near the apex of the heart, and that is between the 5th and 6th intercostal spaces, and it's on the other word for it that you need to know is left midclavicular line, and so that's also going to be the apical pulse. Apical pulse, left midclavicular line, 5th intercostal space. We will auscultate for a full 60 seconds. You need to understand those terms and those landmarks when it comes to auscultating the apical pulse. So I'll say it again. Left mid-clavicular line, 5th intercostal space. You have to listen for a full 60 seconds, okay? All right, we will talk about the flow of blood through the heart. When we think about the flow of blood through the heart, I want you to think right side. That's where the blood is returning from the body. That blood is deoxygenated, oxygen poor, and it's going to enter via the vena cava, superior, inferior, going to go to the right atrium. Then that blood will pass through the right atrium through the tricuspid valve to the right ventricle. Then that blood will pass through the pulmonary valve. Then it will go to the pulmonary arteries, which will then go to the lungs. Now that blood in the lungs will drop off carbon dioxide and pick up oxygen and return to the blood via the pulmonary vein to the left atrium. Okay, so right side of the heart, that blood is deoxygenated. It's sent to the lungs to drop off carbon dioxide, pick up oxygen. Then that oxygenated blood comes back into the left atrium via the pulmonary vein. Then that blood will pass by the mitral valve. The mitral valve is also known as the bicuspid valve. Then that blood will go into the left ventricle. From the left ventricle, that blood will pass through the aortic valve and then go to the aorta. Please keep in mind that the left ventricle is the largest, most muscular chamber of the heart because it has to forcefully push blood through the aorta and to the rest of the body, okay? So that is the flow of blood through the heart, and it's kind of important for you to understand that. So if a patient has left-sided or right-sided heart failure, you can understand the flow of blood and how the patient will present. All right, so let's talk about our cardiovascular diagnostic procedures. So let's take a look at an overview of the cardiovascular status first. So when we think about the cardiovascular system, we're thinking the heart, which is a four-chambered pump, the two atria at the top and the two ventricles at the bottom. Both atria beat together, that is your lub or your S1 sound. Then your ventricles are beating together, that is your dub or your S2 sound. So when we think about cardiovascular system combined with the circulatory system, we have to include blood, and we also have to include the blood vessels. The blood itself is made up of plasma, red blood cells, white blood cells, and platelets. The blood vessels themselves are the arteries and veins. The arteries branch into smaller branches called arterioles. The veins branch into venules, and then the tiniest of vessels are actually capillaries. Okay, so just a quick A&P review of those terms. So when we think about the heart, it efficiently pumps blood to all parts of the body, and that indicates a healthy working cardiac muscle, healthy working cardiac system. Circulation needs to be adequate, right, to meet the body's needs. We have to have an appropriate amount of blood in order to meet the body's needs. Adequate blood pressure is maintained by peripheral vasculature. When you think vasculature, I want you to think about the veins and arteries and capillaries. The normal heart rate for an adult is between 60 to 80 beats per minute. All right, let's talk about the laboratory values. So serum electrolytes, right? And so that includes your sodium, your calcium, your potassium, magnesium, your chloride, right? So all of those lab values you must be familiar with. Other diagnostic procedures when we're talking about cardiovascular health could be your ESR or your erythrocyte sedimentation rate. So if your erythrocyte sedimentation rate is elevated, that can signify that there is inflammation in the body. Okay, and we use the ESR for more than cardiovascular. We can use it if the patient has autoimmune condition. We'll see that the ESR is going to be elevated. Another lab test to mention is the C-reactive protein, right? And that is going to be specific for our potentially heart patients. Also, we will look at blood coagulation tests, right? PTT, which is most significant if the patient is on heparin therapy, and PT is most significant if the patient is on warfarin therapy. So I'll say it again, PTT for heparin and PT for warfarin, okay? So another blood coagulation test to monitor is INR. We also have to look at the BUN and the creatinine. And so the BUN and the creatinine levels reflect the renal function and perfusion. And so levels of BUN and creatinine may increase if a patient has myocardial infarction, congestive heart failure, or cardiomyopathy. So just to review for a moment, your lab functions, a normal BUN is going to be 10 to 20. A normal BUN is 10 to 20 milligrams per deciliter. The serum creatinine in males should be 0.6 to 1.2 milligrams per deciliter. For females, it's 0.5 to 1.1 milligrams per deciliter. So again, for renal function, serum creatinine and BUN, okay? So those are things that we can look at also with our cardiovascular patients. We'll also take a look at their serum cholesterol levels, particularly their LDL, which is your bad cholesterol, and your HDL, which is your high density lipids, and that's going to be your good cholesterol. LDL stands for low density lipids. We also will take a look at the triglycerides. Another lab value will be B-type natriuretic peptide, or BNP, Bravo November Papa, and this is an indicator for diagnosing heart failure. So a critical value is going to be greater than 100 picograms per milliliter. So remember 100, if it's greater than 100, that is a critical value. The other lab value that we'll look at with our cardiovascular patient will be those cardiac enzymes. And so these enzymes can indicate the death of myocardial muscles or a heart attack, right? So we have the creatinine phosphokinase MB. So that is also known as the CKMB. This is an isoenzyme and it increases within 4 to 6 hours following the MI, and it remains elevated from 24 to 74 hours after the event. So that is your creatinine phosphokinase MB. So CKMB is an isoenzyme that increases within 4 to 6 hours following the MI and remains elevated from 24 to 72 hours post the event. Okay, the next enzyme, cardiac enzyme we're going to look at is going to be troponin. Troponin. Troponin is a protein that is considered the gold standard for diagnosing MI. Troponin is a protein that is considered the gold standard in diagnosing MI. It remains elevated for 2 to 3 weeks following an event. It remains elevated for 2 to 3 weeks following an event. Normal level is less than 0.2 nanograms per deciliter. 0.2 nanograms per deciliter for troponin. And again, that is the gold standard. Okay, whenever something is the gold standard, that means it's the best, okay? Myoglobin is the next lab value, and it rises early in response to tissue injury within the first 2 hours. Okay, so this is kind of like, hey, a heads up that this is coming. This patient may not have had an MI yet, but it's coming. So it also declines very quickly after 7 hours of injury, right? So the myoglobin is also less useful than CKMB and troponin, since myoglobin is present in skeletal as well as cardiac muscle. So here's an example. A patient presents to the emergency room complaining of left-sided chest pain. We're going to do those, these diagnostic tests, but this patient is also a post-surgical patient, post-operative patient, so they have an incision, they have a wound. Well, I know for a fact if they have a wound or an incision from where they had surgery a few days ago, their myoglobin's going to be elevated. So that's really not going to be a reliable kind of test when it comes to this patient that's, having this cardiovascular kind of event. Okay, so the next diagnostic procedure to speak of when we talk about cardiovascular health is going to be your electrocardiogram, known as the ECG or an EKG. So this EKG is a recording of the electrical activity occurring in the heart. So a 12-lead EKG should be obtained within 10 minutes of onset of chest pain to identify any areas of myocardial damage. So we have the P, Q, R, S, and T. portions of this EKG, the P wave represents atrial depolarization, or the atria are contracting during the P wave. The QRS complex represents the ventricular depolarization, or my ventricles that are contracting. Okay, now the T wave represents ventricular repolarization. This is when the ventricles are relaxing and filling up with blood. The right ventricle is filling up with blood to send to the lungs. The left ventricle is filling up with oxygenated blood to send to the rest of the body. Okay, so that's going to be important to understand the PQRST, right? So if the patient has an EKG and there is a T wave inversion, that represents ischemia. Ischemia means that there is a lack of oxygen due to a blockage in a vessel, so that part of the heart does not get adequate blood flow. Okay, so ischemia is lack of blood flow, lack of perfusion, lack of oxygen, lack of nutrients. If this tissue does not have blood flow, the cells beyond it cannot survive. Okay, so that is T wave inversion, ischemia. ST segment elevation indicates injury. ST segment elevation indicates injury. Okay, sometimes you will hear a STEMI alert, right? When you're in your clinical setting, you may hear STEMI alert, and that's what they're referring to, that ST segment elevation, okay? So Q wave enlargement, right? If the Q wave is enlarged, that tells us that there is an infarction, okay? That tells us that there is infarction for your cardiac patient, okay? So I think those are all the terms that you definitely need to know when it comes to your cardiac PQRST complex. So just to make sure it's clear, T wave inversion, there's ischemia, there's lack of blood flow. ST segment elevation, that's going to indicate injury. Q wave enlargement indicates infarction, and infarction means the death of the tissue, right? So first we'll see ischemia, and then later on we could possibly see infarction. That's why an MI, myocardial infarction, part of the heart's muscle tissue is going to die, right? And so that dead tissue is sometimes called an infarct, okay? INFARCT, so infarct. Okay, so let's now jump to cardiac catheterization. This is a procedure that involves the advancement of a catheter, usually through the femoral artery into the coronary arteries. So this is in the groin, folks, where we are inserting this catheter into the groin. So dye may be injected to visualize the blockages, which can then be treated with percutaneous coronary intervention. Percutaneous coronary intervention. This is also known as PCI. The femoral vein can also be assessed to perform other assessments of cardiac function. But usually I see these questions for cardiac cath is going through the femoral artery and the groin. And we're going to talk about your nursing interventions, because those are the things that test questions are made of, right? And NCLEX questions. So the types of PCI, remember PCI is percutaneous coronary intervention. So coronary angioplasty is the first one. So with coronary angioplasty, a balloon-tipped catheter is used to press the coronary blockage open to improve blood flow. Again, coronary angioplasty. A balloon-tipped catheter is used to press the coronary blockage, right? That coronary blockage open to improve blood flow. Okay, so that's important to note. Now, a coronary stent, the second type of PCI, this is a procedure performed during angioplasty that leaves a metal mesh in place as a structural support to prevent the blockage from reoccurring. So if you ask your patient, do you have any hardware or anything that you weren't born with. They may say, yes, I have a stent in my heart. That's what they're talking about. Okay, or they may have a stent in one of their blood vessels. So when we think about this cardiac cath or cardiac catheterization, the purpose is to perform this angiography, to perform PCI, and PCI again is percutaneous coronary intervention, life-saving method measures here. So obtain information about this cardiac structure and blood flow. So that is all under the purpose of cardiac catheterization. Also to obtain blood samples and also to determine cardiac output. Again, those are all the purposes of cardiac catheterization. Now, the nursing interventions, and this is again what test questions are made of. Prior to catheterization, we have to verify that the procedural consent has been obtained, scanned into the patient's record. We have to know the approach. Are they going on the left side or going on the right side? And we have to prepare that area. So we may have to shave, clip down the hairs, right? We will prep that area, maybe clean with iodine, clean with CHG, whatever is prescribed. We will prep that area. A right approach will signify a venous approach, or a left approach will signify an arterial approach. Okay, so again, know the approach, and you may see it in test questions. They'll usually tell you the approach: a left femoral catheterization, right femoral catheterization, right? So the thing that's important to note, where they make the approach, where they're actually going to stick the catheter in, you want to make sure that you assess that extremity, the lowest possible area, the most distal. So what does that mean? If they're making a right femoral approach, I better be checking my right dorsalis pedis pulse. Now, of course, you're always going to check the pulses bilaterally, but specifically, if you get a hotspot question where you have to put the cursor on top of where you're going to check, you want to check the pulse that's the most distal, and that is your dorsalis pedis pulse on the right side if they're making a right approach. Okay, now before the procedure, you're going to make sure that the patient is going to be NPO for at least 6 hours. You're also going to mark those distal pulses. So yep, you'll mark it with a Sharpie or whatever device they want you to use to make sure we know where those pulses are, because sometimes it's hard to find the pulse for this patient, but it's important we know exactly where those pulses are. Pre-procedure, we also want to explain to the client that the procedure may have a metallic taste in their mouth, and they may feel warm when that dye is injected. And of course, we're going to verify that the patient does not have any history of allergy to dye or to shellfish or iodine. So that's going to be important. After cardiac catheterization, this is super duper important. This is what NCLEX questions are made of. Okay, so when we think about this cardiac catheterization, okay, let me just make sure my showing my slides. Okay, just 1 second. Okay, let me pause for a second. Okay, I'm back. I just wanted to make sure that I was recording the right screen here. So the correct screen. So and again, after catheterization, this is what our test questions are made of, okay, for sure. So after catheterization, we're going to monitor the client's blood pressure and apical pulse every 15 minutes for 2 to 4 hours. So this patient is not stable. The care of this patient should not be delegated to an LPN or to an unlicensed assisted personnel. This is a patient that the nurse must, or registered nurse must care for. So again, monitor the client's blood pressure and apical pulse every 15 minutes for the next 2 to 4 hours. Other interventions include perform a neurovascular assessment on the client every 15 minutes for the first 2 hours, and then every 30 minutes until the client is able to sit up. So again, perform a neurovascular assessment on the client every 15 minutes for the first 2 hours, then every 30 minutes until the client is able to sit up. Monitor for bleeding and or hematoma at the catheter insertion site. Now, a small hematoma could be expected, right? But if we start to get a large hematoma, that will become concerning. All right. And a hematoma is just a blood bruise, right? And so, of course, if we stick a needle into the skin, we could expect that there's going to be a tiny bruise, and that's okay. But when it becomes large, and I'm thinking, if it starts becoming larger than a dime, a quarter, I'm really getting concerned. Okay. But it should just be like the pinprick, right? Or the diameter of the catheter. Okay. But not any larger than that. All right, we will apply pressure for a minimum of 15 minutes to prevent bleeding or hematoma formation. We will monitor the patient for vasospasm, dysrhythmia, or rupture of the coronary vessel. We will assess the client for chest pain, and we will keep the extremity extended for 4 to 6 hours. So they're going to be not getting up right away, because I've seen a lot of test questions on this cardiac cath patient. They're not getting up right away. They're going to be hanging tight. They're going to be in the supine position. They're not going to be flexing their hips, right? They're not going to be sitting up, at least for the, post 4 to 6 hours, okay? That's really, really important that you understand that. Many, many, many questions can appear from that procedure. All right, let's talk about the transesophageal echocardiogram. So this is a diagnostic tool that's used to visualize structures, including the valves and the functions of the heart. This is used for diagnosis of heart failure and murmurs. So if you saw this on the test and you're like, man, I don't know what a transesophageal echocardiogram is. Well, we know a normal echocardiogram looks at the heart, the cardiac output, looks at the valves. Transesophageal, that's saying maybe they're going to make the approach through the esophagus. And that's exactly what it is. So if you see a phrase or a term and you're like, I don't know what that means, try to break it down. So for this transesophageal echocardiogram, we are going to, for pre-procedure, the patient's going to be NPO, nothing by mouth, for 6 to 8 hours prior to the procedure. We will clarify any medications to be administered, and we will clarify that with the provider. Post-procedure, test question, test question, test question. Assess for adequate gag reflex. Whenever we're doing anything with the patient's throat, esophagus, right, their neck, always, always, always make sure that the patient has a gag reflex. We will give nothing by mouth until that gag reflex has returned. Monitor respiratory effort as client recovers from sedation. Observe oral secretions. Are they blood tinged? Right now, blood tinged secretions may be common in early recovery, and so that is to be kind of expected. Okay, but if it's many hours afterwards, or we're getting bright red blood, we're getting clots, that's something we have to notify the provider immediately. All right, so that is your transesophageal echocardiogram. Let's now go to our conditions, our disorders. So we're going to be talking about angina, MI, heart failure, valvular disorders, aortic aneurysm, hypertension, peripheral vascular and venous disease, VTE, varicose veins, Berger's disease, which is also known as thromboangiitis obliterans. That's a mouthful. So we'll talk about that, and we'll talk about Raynaud's syndrome. All right, let's start with angina. All right, angina is a manifestation of myocardial ischemia caused by arterial stenosis or blockage, uncontrolled blood pressure, or cardiomyopathy. I'll say it again. Angina is a manifestation of myocardial ischemia caused by arterial stenosis or blockage, uncontrolled blood pressure, or cardiomyopathy. So we have chronic stable angina, acute coronary syndrome, right? So when we think about chronic stable angina, this is chest discomfort, and it's kind of typical. It's usually relieved by a single nitroglycerin. So chronic stable angina is really most likely because of the patient having atherosclerosis, or those plaques built up in their vessels. And that's what the picture is showing you. right? Now, acute coronary syndrome, this is a patient that is experiencing unstable angina, okay, or an acute myocardial infarction. Unstable angina is characterized by chest discomfort described by the client as occurring at rest or with activity and may last longer than 15 minutes unrelieved by nitroglycerin. So just a reminder about nitroglycerin, we have that 15-minute rule, right? So take the first dose, call 911, wait 5 minutes, take the second dose, another 5 minutes, right? So in 15 minutes, the patient should have taken 3 doses of that nitroglycerin because we don't know if that chest pain is angina or if it's an actual myocardial infarction, okay? Now, when we talk about the types of angina, because we mentioned chronic stable angina and acute coronary syndrome, when we think about the types of angina now, there could be stable or exertional angina. So this is basically the patient is fine, but when they start moving around, shoveling snow, doing something, some physical workout, or they have emotional stress, they can have this pain. And this is usually relieved by nitroglycerin. That is stable angina. Unstable pre-infarction angina. Well, this occurs at exercise or at rest. So this increases in occurrence, severity, and duration over time. So if you are familiar with Sanford and Son, and whenever Fred Sanford, his son Lamont, like stresses him out and he grabs his chest, he's like, Elizabeth, I'm coming to join you, right? So that is an example of stable angina, like because he's fine until Lamont starts stressing him out. And so now he's got this emotional stress and he's like, oh, I've got this chest pain. So that's an example of stable angina. Unstable angina, which is more serious because it even hurts when the patient is at rest. Okay, so contributing factors to angina, well, contributing factors to coronary artery disease can be family history, advanced age, hyperlipidemia, right? That's your high cholesterol, tobacco use, hypertension, diabetes mellitus, obesity, and physical inactivity. Okay, so for this patient, the manifestations can be chest pain or discomfort, pain in the arms, neck, jaw, shoulder, or back. And that is also called referred pain, right? When that pain radiates from the actual source of where the injury is. Okay, nausea, fatigue, shortness of breath, anxiety, diaphoresis, dizziness. You've got to know these kinds of signs and symptoms because that could definitely be how a patient is presented to you in a test question. And you have to know, okay, this is definitely a cardiac kind of scenario. So what would I do for this patient, right? Diagnostic procedures. I would expect to see 12-lead EKG, stress test, cardiac catheterization, echocardiogram, cardiac enzymes, and biomarkers. And remember, we will always start with our least invasive processes, right? And then work our way up, right? But that EKG must be given within 10 minutes, so right away. Okay, so our nursing interventions, considerations, assess the client's pain using a pain rating scale. We're going to determine the location of the pain. Is it spreading in the jaw, the arm, the chest? What is the character of the pain, the duration of the pain, right? Is it relieved with rest or with nitroglycerin? What were the precipitating factors? Were they just sitting down watching TV or were they, shoveling snow, right? We have to understand what was the cause of this possible pain. We will provide environment that is conducive to rest and avoid activities. The medications that could be administered for this patient with angina include aspirin, nitrates, beta blockers, statins, calcium channel blockers, angiotensin converting enzymes, or your ACE inhibitors, right? So again, the medications I could expect to see: aspirin, nitrates, beta blockers, statins, calcium channel blockers, angiotensin converting enzymes. So client education is going to be important for your patient with angina. Lifestyle changes are going to be important, avoiding constipation, avoiding excess activity in cold weather, that's that shoveling snow, decreased stress, exercise, maybe some yoga would be great, consume low sodium, low fat diet, maintain a healthy weight, rest after meals, and of course, promote tobacco cessation. We will also provide teaching on the correct use of nitroglycerin. So we already mentioned that, right? And that's going to be important to when we talk about the administration of nitroglycerin. Remember that nitroglycerin should be kept in a dark container away from light and sunlight in a cool room, right? And nitroglycerin can be given in form of tablets, ointment, patches, or sprays. Remember to use gloves, right, when we are handling this medication. If the patient is at an in-home setting, they will remove the patch and close it with the medication side on the inside and put it, that used patch, in a closed receptacle so children and animals cannot get into it. So erectile dysfunction medication is contraindicated while the patient is using nitrites. All right, let's now go to myocardial infarction. So this is the big one. So this is a process in which myocardial tissue is destroyed due to reduced coronary blood flow and lack of oxygen. Actual necrosis, which is cell death of heart muscle, occurs, and that heart muscle is also known as the myocardium. So contributing factors to myocardial infarction, also known as MI, will be atherosclerotic heart disease, again, that atherosclerosis, plaques in the blood vessels, coronary artery embolism, coronary artery embolism. What are the manifestations? Severe chest pain, unrelieved with nitroglycerin or rest, crushing quality, it radiates to the jawline, left arm, neck, and or back. So they may say, whoa, an elephant is sitting on my chest, right? So this is what we're talking about with the myocardial infarction. Now, women and older adults and patients that have diabetes mellitus, they can often report no pain, right? So that's important to note that women, especially your diabetics as well, they may present with different symptoms. So other manifestations of MI can also include diaphoresis, nausea, vomiting, anxiety, fear, vital sign changes like tachycardia, hypotension, dyspnea, dysrhythmias, right? So these are all things to look for in our patient that could be having an MI. Diagnostic procedures will include lab work. So we're looking at troponin, which will be elevated, CKMB, which will be elevated, and also myoglobin. We would expect a 12-lead EKG ASAP, right? We want to identify if there's any ST changes. Okay, so it may be an ST elevation MI or a non-ST elevation MI. And remember, ST elevation, right? ST elevation tells us that the heart has injury, right? And so that's going to be really important. Again, that is your STEMI alert that you hear over the announcing system. So nursing interventions for this patient with an MI, right? We are working on resting the myocardium and preserving the remaining heart muscle. So if it's early, we want to early onset of MI, administer oxygen, administer medications to include aspirin, antidysrhythmics like your amiodarone or your lidocaine. Analgesics will be morphine sulfate. Anticoagulants could be heparin, right? Thrombolytics must be given within 6 hours of the cardiac event. Thrombolytics will help to bust up those clots, right? And so we're thinking about streptokinase or altiplase recombinant, okay? So again, these thrombolytics must be given within 6 hours of a cardiac event. We will also probably have to administer vasodilators, right? That's your nitroglycerin. Beta blockers, that's your metoprolol. Calcium channel blockers like verapamil or nifedipine. Calcium channel blockers like verapamil or nifedipine. We will also frequently monitor the vital signs, the O2 saturation and EKG. We will provide emotional support to the client. Now, later on, right, and let me just backtrack for a second. When I mentioned all of those medications and the interventions, I want you to also be aware of MONA, MONA, like Mona Lisa, and that stands for morphine, oxygen, nitroglycerin, and aspirin. Now, of course, if the patient is allergic to any of those medications, you would not administer. Okay, so going back to our nursing care later on, administer stool softeners to prevent straining with bowel movements or the Valsalva maneuver. Okay, we don't want our cardiac patients to be constipated. We don't want them to strain. If we do, that stimulates vagus nerve, that's cranial nerve number 10. The patient can drop their heart rate and end up passing out, right? We don't want that to happen. So we will also provide a soft, low-fat, low-cholesterol, low-sodium diet. The patient will use the bedside commode, which requires less energy than using a bedpan. Yes, because it's more natural for us to be sitting up, going to the bathroom, than lying down. If you've ever tried to use a bedpan, you know that's true. Okay, we want to promote self-care, instruct the client to stop at the onset of pain, plan for cardiac rehabilitation, which is tertiary prevention, in case you see that kind of question. There's secondary, primary, secondary, and tertiary prevention. Cardiac rehab is an example of tertiary prevention. We'll also initiate an exercise program, but stop if fatigue or chest pain occurs. Teach and encourage the use of stress management techniques. We will also monitor the patient for any of these risk factors: obesity, stress, diet, hypertension, tobacco use, physical inactivity. So those are things that the patient can change. We also want to recognize that we can't change hereditary, race, age, and gender. All right. We will also ensure bleeding precautions when the patient is prescribed anticoagulants and antiplatelet therapy. So there is going to be a long-term medication therapy, and that will consist of anticoagulants, antiplatelets, heparin in the hospital setting, and then warfarin once the patient goes home. We don't send our patients home on heparin. They take heparin until they get to a therapeutic level as far as their clotting goes, looking at their platelets, and then warfarin will be what they take when they go home. Sometimes they can also be prescribed an enoxaparin, which is also Lovenox. The patient may also be prescribed antihypertensives to include possibly beta blockers like your metoprolol, your calcium channel blockers like your diltiazem, or vasodilators can also be given like your nitroglycerin, and your anti-lipidemics or your statins, your simvastatin or your atorvastatin can be given as well. All right, so that is the down and dirty on your patient that may have had a myocardial infarction. Let's talk about heart failure. Heart failure is the inability of the heart to meet the tissue requirements for oxygen, and this is characterized by manifestations of fluid overload or inadequate tissue perfusion. So it has been called congestive heart failure due to the frequent occurrence of pulmonary and peripheral congestion. Okay, this is most often a chronic condition with the goal of preventing acute exacerbations. That is our goal. Now, this heart failure patient, you're going to definitely see this as test questions. This patient has fluid volume overload. So I would question, or I would get clarification from the provider if this patient was prescribed IV fluids, right, at 100 mLs per hour. That's going to require some kind of, clarification for me, okay? So we have the two different kinds of heart failure. There's left-sided heart failure and right-sided heart failure. So the signs and symptoms of left-sided heart failure. So left, I want you to think lungs. So what is this patient going to look like? What are the manifestations? Well, dyspnea, cough, crackles, orthopnea. Orthopnea means that they have to sleep in an upright position over the bedside table or with pillows. Again, that's orthopnea or the orthopnic position. This left-sided heart failure patient may also have paroxysmal nocturnal dyspnea. So at night, they'll be like, and they'll feel like, oh man, I'm choking on my own fluids, right? That's paroxysmal nocturnal dyspnea. So they also may have low oxygen saturation levels, and they may have an elevated pulmonary artery wedge pressure. I'll say it again, pulmonary artery wedge pressure. That makes sense. Left side, we think lungs, right? So pulmonary artery, we're thinking pulmonary's lungs, okay? So that's going to be for your left-sided heart failure. Right-sided heart failure. So remember, the right side is the part of the heart that receives deoxygenated blood to send it to the lungs, right? So a patient with right-sided heart failure, this is going to be related to systemic congestion. This patient is going to have dependent edema, edema of the lower extremities, specifically over the ankles and shins, right? So we have plus 1, 2, 3, 4, pitting edema, weeping edema, right? This right-sided heart failure patient can also have hepatomegaly, splenomegaly, right? Enlargement of the liver or the spleen. They may have ascites, a round protuberant abdomen, right? We have to look out for varicosities as well. This right-sided heart failure patient may also have anorexia and vomiting, weakness, weight gain, jugular venous distension, elevated CVP, which is central venous pressure, right? And so that makes sense because the pulmonary artery wedge pressure was for left-sided heart failure, but the central venous pressure, that's going to be for your right-sided heart failure patient. So what are nursing interventions for a heart failure patient? Well, we want to assess their respiratory status, auscultate the lung sounds, and detect any crackles and or wheezes. We will initiate oxygen therapy as needed, and they will be in the Fowler's position to help the work of breathing. High Fowler's position is not a position that we normally leave our patients in. High Fowler's is kind of like a temporary thing if the patient is in distress or if we're inserting a nasogastric tube or that kind of thing, or if they're eating, lunch or dinner or a meal, but we don't usually leave our patients in the high Fowler's position. So that's important. Okay. So for other nursing interventions for your heart failure patient, fluid restriction may be implemented depending on the severity. They will have a low sodium diet, and so that's less than 2,000 to 3,000 milligrams of sodium per day. And we will definitely report a 2 to 3 pound weight increase in one day in 24 hours. So yes, this heart failure patient is going to be on daily weights. Every morning after they empty their bladder is the best time to weigh this patient. All right. And in one 24-hour period, if they gain 2.2 pounds, I'm concerned because 2.2 pounds is equal to 1 liter of fluid. So I've got to figure out, where is this fluid located? Is it on their, shins? Is it in their lungs, right? So when we think about heart failure, the pharmacological therapy that they can receive could range from ACE inhibitors, hydralazine and nitrates, your ARBs, your angiotensin receptor blockers, medications, your beta blockers, your calcium channel blockers, your diuretics, digitalis, also digoxin, IV nersurteride, IV dobutamine, right? Dobutamine. So those are going to be things that you could see for pharmacological therapy for your heart failure patient. Okay, let's jump into valvular disorders. So earlier we mentioned that we have 4 valves in the heart, right? So we have these 4 valves, and this picture on the slide shows you a normal valve that is closed. Now, the one to the right shows you valve that has stenosis, right, or a narrowing. And the problem with these valves not closing is that these valves in the heart, the 4 of them, they ensure that we have one-way blood flow in the heart. If those valves do not close all the way, or if they are damaged, now we're going to have backflow of blood, and that is called regurgitation. Okay, and so with these valvular disorders, there's a narrowing of the valve that prevents or impedes, blocks flow. There could be stenosis or impaired closure that allows that backward leakage of blood. Again, that is called regurgitation. And so it can affect the mitral, aortic, or the tricuspid valve. So contributing factors for a patient having valvular disorders. Well, they could have a history of endocarditis and rheumatic fever, right? And that's frequently the cause. So whenever you see that patient that has had a strep throat infection 2 to 6 weeks ago, and now they have rheumatic fever or scarlet fever, that's what we're talking about. I'm scared of heart valve damage, okay? So manifestations of valvular disorder. Well, right-sided, we're looking at the mitral stenosis or mitral regurgitation or tricuspid stenosis. Left-sided heart failure, this is aortic stenosis, aortic regurgitation. And when I auscultate the patient's heart sounds, right, this can also be manifesting as a murmur. So that's why it's important to auscultate those landmarks, those cardiac landmarks, and then think about, okay, do I hear lub dub? Do I hear an extra sound? All right. The other manifestation of a patient that may have valvular disorder may be a decreased cardiac output. So what are my nursing interventions for this valvular disorder patient? Well, we want to manage them, and it's very similar to the patient that has heart failure, right? So the patient may also have a valvuloplasty, right? And so where it's similar to a PCI, right? Percutaneous intervention, right? Percutaneous catheterization. So what we have to do for this patient that's having the valvuloplasty, we have to look out for signs of systemic emboli. And so maybe there was a blood clot, now it has been dislodged from the valve and it's floating around, and that's when it becomes an emboli. All right, so this patient may also have to have a valve replacement. And so this is a mechanical kind of valve replacement. And so they will require lifelong anticoagulants to include warfarin. We want the INRs to be between 2 to 3%. Okay, biologic. So this patient will only require prophylactic anticoagulants for 3 months. So that's what we're talking about with our valve replacement. Now, all patients that have undergone valve surgery, they will require, test question, test question, test question, they will require prophylactic antibiotics prior to any future invasive procedures or tests, to include dental procedures to prevent infective endocarditis. So this I see a lot as an NCLEX kind of question. Any patient that has had a valve replacement needs to have prophylactic antibiotics prior to any invasive procedures or tests, okay? All right, let's talk about aortic aneurysm. Now, aortic aneurysm. All right, so when we think about aortic aneurysm, okay, we are thinking of a local distension of the aortic artery wall, okay? And so it's usually thoracic or abdominal. So remember in health assessment when your teacher said use the bell of your stethoscope to auscultate for any bruits in the abdomen, this is what you were looking for, this aortic aneurysm. So this aortic aneurysm is monitored until it gets to about 5 centimeters, okay? So once it's larger than that, the rate of rupture increases and surgery is usually required, okay? So that's, pretty serious there. It becomes pretty serious. Okay, so what are the contributing factors for an aortic aneurysm? Well, atherosclerosis, we see that again, infections, inflammatory disorders, connective tissue disorders. The manifestations, the patient is frequently asymptomatic. So they can have also, though, thoracic pain. They can have dyspnea, hoarseness, cough, dysphagia. Abdominal-wise, they may have abdominal pain, right? So they can have a thoracic aneurysm or an abdominal. So thoracic aneurysm, they can have pain, dyspnea, hoarseness, cough, or dysphagia. Now with this abdominal aneurysm, aortic aneurysm, because the aorta does go all the way down, right, through our body, right? they can have the abdominal aneurysm, which is manifested with abdominal pain, persistent or intermittent intermittent low back or flank pain, pulsating abdominal mass. Okay, so that's really important, that pulsating abdominal mass. That's kind of like a big kind of test question. Okay, so again, thoracic manifestations of thoracic aneurysm, thoracic aortic aneurysm, pain, dyspnea, hoarseness, cough, or dysphagia. Abdominal aortic aneurysm, abdominal pain, persistent or intermittent low back or flank pain, pulsating abdominal mass. All right, so with this aortic aneurysm, again, you can see it thoracic or you can see it abdominal. Diagnostic procedures, CT scan, MRI, X-ray, ultrasound. What are the nursing interventions for this patient? Nursing considerations? Well, treatment often includes surgery. So preoperative, we want to maintain a systolic pressure at 100 to 120 milligrams of mercury, right, with beta blockers. So 100 to 120, millimeters of mercury, right? So that's just your top number. We're talking about your systolic number, 100 to 120. And we're going to use beta blockers to help do that. Or we can use other antihypertensive medications such as hydralazine. We would also expect that there's going to be a continuous IV nipride, which may be required for this patient. We will also monitor closely for the manifestations of rupture, and they will be intense pain and decreasing blood pressure because the patient's going to be literally having their heart pumping to a vessel that has a hole in it, okay? So this can also, you can see the signs and symptoms. You must be thinking peritonitis, right? Hot belly, right? Which we're going to talk about in the GI system. But absolutely. Now, post-operatively, what would you see in an aortic aneurysm? Careful monitoring of the peripheral circulation below the level of the aneurysm, right? We want to make sure that blood flow is getting to the most distal extremities. Close monitoring of the blood pressure continues. Low blood pressure, as you and I both know, may indicate hemorrhage. High blood pressure places stress on the arterial suture line, right? Because they actually have to go in and sew up that hole. They have to suture it up. So if there's high arterial pressure, that's going to place pressure on that suture line. Post-operative complications to look out for. This is also another great, test question kind of thing. We have to look out for arterial occlusion, hemorrhage, infection, and renal failure, okay? So aortic aneurysm, another great one to know. Hypertension. So this is a persistent blood pressure above 140 over 90. Okay, millimeters of mercury. It's often called the silent killer. Again, persistent blood pressure above 140 over 90. Primary hypertension, the most common type, that's 90% of the cases, and it is a hereditary disease. The cause is often unknown, more common among African Americans. Late manifestations, headaches, fatigue, dyspnea, edema, nocturia, blackouts. Again, late manifestations, test questions are made of these things. Headache, fatigue, dyspnea, edema, nocturia, and blackouts. Usually no manifestations until end organ involvement occurs, okay? So that's why annual physicals are so important for our patients. Now, secondary hypertension, it is due to an identifiable cause. It could be due to renal damage, right? Now, when we think about what we have to do for nursing interventions and nursing considerations for this patient, we're going to teach weight control, encourage tobacco cessation, decrease alcohol and caffeine intake, promote a program of regular physical exercise, promote a lifestyle with reduced stress, reduced sodium, also the DASH diet, right? The dietary approaches to stopping hypertension. So if you've been to the supermarket and you see Mrs. Dash, that is what we're talking about, right? Increased fruits, vegetables, low-fat dairy, limited saturated fats. Now, the medications we could expect to see, right, for this patient with hypertension. So it could include diuretics and or beta blockers. So loop diuretic could be your furosemide or your bumetanide, right? We also may see prescribed for this hypertensive patient thiazide, hydrochlorothiazide, right? Your HCTZ, right? So interventions for loop and HCTZ diuretics, right? When my patient is taking these diuretics, what do I have to watch out for? Well, administer potassium supplements as prescribed. So this tells me that I have to carefully monitor this patient's potassium levels. I also have to teach the patient dietary sources of potassium, because if their potassium is low, then hey, they need to eat more spinach, more bananas, right? More kale. If their potassium is high, then you might want to refrain from eating all those bananas and spinach and kale, right? Now, hypokalemia increases the risk of digitalis or digoxin toxicity. All right, so that's very important to note. If your patient is taking potassium-sparing diuretics, again, we want to carefully monitor their potassium levels. The potassium-sparing diuretics include spironolactone, right? And so again, we have to monitor for increased potassium level. If your patient is taking a potassium sparing diuretic and then you get their blood work back and their potassium is a 6.0, I would recommend that that patient not be on a potassium sparing diuretic. They also have to probably have dietary changes, right? Because that patient may eat 5 bananas a day or something. They may have all these banana smoothies, and that could affect them as well. Okay, so now you're again more interventions with this patient that has hypertensive or hypertension. They could be on beta blockers. So that's your propranolol, your atenolol, and your metoprolol, right? So nursing interventions for beta blockers. We want to monitor for signs of bradycardia, monitor the pulse daily, monitor for manifestations of heart failure. And the non-cardioselective beta blockers may be contraindicated in clients who have asthma. So if you see a test question and it has the LOLs and the patient also has asthma, I'm going to get clarification from the provider, okay? So that's what that is meaning. Okay, we also will monitor for hypoglycemia in clients who may have diabetes mellitus, that because they may mask the manifestations of hypoglycemia, right? So that diabetic patient that's taking your beta blockers, we have to be very careful about that, okay? So we also may see your hypertensive patient having to take central acting alpha blockers. That's like your clonidine. They may also have to take ACE inhibitors. That's your prils, your captoprils, your lisinopril, your enalapril. They also may be prescribed calcium channel blockers. That is your nifedipine, your verapamil, your diltiazem, right? So here's some considerations for your geriatric patient. Medications start at half the dose used in younger clients. Also, for your geriatric patients, monotherapy is desirable due to simplicity and decreased expense. The third consideration for your geriatric patient, an increased risk for postural hypotension secondary to medications. So I'm concerned about this patient having this postural hypotension. They are a fall risk. They need to push the call bell before they get up and get out of bed to make sure that they stay safe. Okay, let's continue now and talk about peripheral vascular disease. So when we give the overall umbrella term of peripheral vascular disease, we're talking about peripheral arterial disease and peripheral venous disorders, okay? So when we say vascular, we're including the arteries and the veins. Okay, so let's take a look at this. I like this slide because it has cool pictures to show you the difference between arterial and venous. You've got to know these differences. You will see these on test questions, okay? So when we think peripheral arterial disease, I want you to think of the vessels that are bringing oxygenated blood to the body, right? So if a patient has peripheral arterial disease, right, this is impairment of blood flow in the arteries that carry blood away from the heart, most common in the arteries of the legs. What are the manifestations of peripheral arterial disease? Okay, what are we going to see? Well, intermittent claudication. You got to know that word claudication. That means how or how, so when they have intermittent claudication, that means it hurts intermittently. If you see the phrase claudication distance, how far can you walk before it starts to hurt? Okay, claudication distance. So if a patient has intermittent claudication, they have pain and cramping when walking, it resolves with rest. Okay, they can also have calf muscle atrophy. The skin appears shiny with hair loss and thickened toenails. They will have poor neurovascular integrity. They can have necrotic ulcers, meaning that the ulcers will look punched out and there's no edema present in your peripheral arterial disease. They can also have tingling and numbness of the toes, cool extremities with poor pulses. So for this patient, your nursing intervention with peripheral arterial disease, exercise therapy. They will walk to the point of pain 3 times a week, encourage tobacco cessation, promote weight reduction, and dependent position relieves pain. Dependent means hanging down. If you hold up your dominant hand and you put up your index finger and your middle finger, you will make a V, right? So that tells you, that V tells you if your patient has a venous disease, you will put their legs up. Now put your hand upside down with the tips of your fingers pointing towards the floor or the ground. That makes an A. That tells us that if a patient has arterial disease, I will dangle their extremities, dangle their legs. Okay, so that's your V and your A. Okay, so again, going back to the peripheral arterial disease, right, we will put them in that dependent position to relieve the pain. We will have therapeutic measures, and they may even have to have surgical treatment for popliteal bypass surgery or angioplasty or stenting. Okay. So peripheral venous disease. So it's pretty much going on, right, with the veins. So this is a disorder that interferes with adequate return of blood flow from the legs. This includes venous insufficiency, venous thromboembolism, VTE, and varicose veins. So, peripheral venous disease includes venous insufficiency, venous thromboembolism, which is also known as your VTE, and varicose veins, okay? So let's talk about the venous side of the house now. Contributing factors. Well, nurses, beware, prolonged sitting and or standing, obesity, pregnancy, thrombophlebitis, manifestations, stasis dermatitis, a brown discoloration. If you look around, you can see some of your geriatric patients, it's summertime, they're wearing shorts, and you can see that by their ankles, they have some darkened skin, right? Brown discoloration. Also, edema, stasis ulcers, and these ulcers are typically found around the ankles. All right, so for peripheral venous disease, what do we do? What's our nursing considerations? Well, elevate the legs 4 to 5 times throughout the day. The patient should avoid crossing their legs, constrictive clothing, or tight socks, and they should wear compression stockings, right? Compression stockings. Now, if a patient has VTE, this is the collective condition of deep vein thrombosis, right, and pulmonary embolism, which is PE. So who's at risk? What are the contributing factors for a patient getting this venous thromboembolism, which could which also includes DVT and PE? Well, immobilized patients, post-surgical patients, trauma, obesity, if they're greater than 65, spinal cord injury, any patient that has a disorder of coagulation, pregnancy, oral contraceptives, right? What are the manifestations of DVT? Well, edema of the affected limb, local swelling, bumping, knotty, red, tender, local induration, venous ulcers around the ankle, reddened and bluish edema is also often present. Diagnostic procedures for this, right? VTE, again, VTE includes DVT and PE. Well, heparin, we're going to monitor the PTT. Warfarin will monitor the INR. Thrombolytic therapy, altiplase, will assess for bleeding and thrombocytopenia. Remember platelets, thrombocytes, so low platelets, right? That's thrombocytopenia. Elevate affected extremity and apply warm, moist compresses. Monitor for manifestations of PE, dyspnea, chest pain, tachycardia, and anxiety. To prevent pulmonary embolism, to prevent VTE, which includes DVT or pulmonary embolism, we want early mobilization of our patient, leg exercise, compression stockings, your SCDs, sequential compression devices, intermittent, sometimes they're called intermittent pneumatic compression devices, right? Prophylactic subcutaneous heparin. All right, so that is your VTE. Let's talk about varicose veins. These are enlarged, twisted, and superficial veins, most common in the lower extremities and the esophagus. Contributing factors, and for the esophagus, that's going to be for your alcoholic patient, okay? So varicose veins, contributing factors, prolonged standing, pregnancy, obesity, hereditary, right? So manifestations, enlarged, tortuous veins in their lower extremities, right? And muscle cramping, pain after sitting, edema after standing. What are your nursing interventions? Well, avoid prolonged sitting or standing. Instruct the client to wear supportive anti-embolism stockings, especially during air flights and pregnancy. Avoid crossing legs, engage in daily exercise, maintain an ideal body weight, elevate lower extremities to reduce edema and promote venous return. Promote circulation with thigh-high anti-embolism stockings, ambulation, and elevation. Medical management of these varicose veins. Well, sclerotherapy is going to be a chemical injection, ligation and stripping of these veins, then that's a surgical procedure, or thermal ablation, which is a non-surgical use of energy or lasers. So that is it for varicose veins. Wear your compression socks, nurses, compression hose, and wear your good fitting shoes. All right, we have a couple more to go. Buerger's disease or thromboangiitis obliterans. So this is recurring inflammation of the arteries and veins. So arteries and veins, because we're going to see a condition that is similar but not the same. So Buerger's disease is arteries and veins inflammation of the lower and upper extremities. And so resulting in thrombus and occlusion, the cause is unknown. So contributing factors can include genetic predisposition, cigarette smoking, and chewing, tobacco use, and it often occurs in men ages 20 to 35. Okay, so I'm emphasizing this because the condition we're going to look at next is similar but different in a couple ways. So for Buerger's disease or thromboangiitis obliterans, they're going to have intermittent pain in the legs, feet, arms, and hands. Pain eases when activity is stopped. And again, that is called claudication. Inflammation along the vein below the skin surface due to a blood clot, right, in the vein. Cold sensitivity is going to be Raynaud's type, and we're going to talk about that in just a minute. Now, this patient that has Buerger's disease, they can have painful open sores on their fingers and toes. Ulcerations and gangrene with amputation are common. So the interventions for this patient with Berger's disease: promote smoking cessation, avoid cold or restrictive clothing. All right. So let's now take a look at Raynaud's syndrome. So this is vasospastic or obstructive condition of the arteries, arterioles of the upper and lower extremities, resulting from exposure to cold stress, more common in women. So Raynaud's syndrome is more common in women, but this is an arterial condition. Remember, Berger's disease with arteries and veins, right? So, contributing factors. Well, blood vessels in the hand and feet appear to overreact to cold or to stress. Manifestations of Raynaud's syndrome: coldness, pallor, pain in the extremities secondary to vasospasm, occasional ulceration of the fingertips, color changes from white to red, and they can be bilateral or symmetrical. So diagnostic procedures: they can do a cold stimulation test, place the hands in a cold water or exposing to cold air to trigger an episode. And these episodes are pretty painful. All right, I've had a nursing student once. She was from New York and she moved to Virginia because she actually had Raynaud's syndrome. So nursing interventions: teach the client to avoid the cold and keep extremities warm, wear warm but non-restrictive clothing. Encourage the client to stop smoking and to limit caffeine intake. Medication of choice will be nifedipine. Okay, so this is your patient that needs to wear oven mitts when they actually are removing things from the freezer. All right, so whirlwind tour of our cardiac conditions. Let's look at this question. By definition, hypertension is untreated systolic or diastolic pressure ranging from, is it A, 120 to 139, B, 110 to 129, or C, 130 to 149? All right. So take a minute to look at this. I'm sorry, I didn't read the question correctly. Pre-hypertension is what it reads. Pre-hypertension. Okay. And the correct answer is going to be A. So a systolic pressure of 120 to 139 or a diastolic pressure of 80 to 89. Okay. So that is your pre-hypertensive patient. So about 25 to 37% of Americans, adult Americans, are pre-hypertensive. All right, so that concludes our huddle. Thank you so much for your attention. And I know that I was talking fast, but I had a lot to tell you. All right, I'll see you next time. Take care and think like a nurse.